As we proceed with today's enriching agenda, we now turn our focus to the free paper sessions. This segment of our conference will showcase the latest research and innovations in the field of urology. Here, emerging and established researchers will present their findings, offering us a glimpse into the future of urological care and treatment. These sessions represent the hard work, dedication, and scientific rigor that embody the spirit of our association. It is my honor to introduce our esteemed judges for this invaluable segment. Professor Joe Criswell, President of British Association of Urological Surgeons. Professor Yasser Farhat, President of Urology Association of Asia. Dr. David Winkle, Immediate Parts President of Urological Association Asia and Urological Society of Australia and New Zealand. Professor Alan McNeil, representing British Journal Urology International. To all our oral presenters, please note that you will have 6 minutes to present your research and further 2 minutes for questions and answers. Let us welcome our first presenter. I invite Dr. Hilary Fernando to present their pioneering work on palliative TURP resectional exploration of intramural ureter and retrograde stenting in locally advanced prostate cancer, an initial experience from the outback of Sri Lanka. Over to you, sir.
A very good morning again. I'm presenting this free paper, Palliative Transurethral Resection of the Prostate, Resectional Exploration of Intramural Ureter, Retrograde Stenting in Locally Advanced Prostate Cancer from Monaragala. This is not the presentation. So prostate cancer is the second most common cancer in men worldwide. It is the 5th commonest cancer in men in Sri Lanka and 6th commonest in the urology clinics in Monaragala. Late presentation with malignant bladder outlet obstruction and malignant ureteric obstruction signifies life-limiting advanced prostate cancer at diagnosis. The current standard of care is percutaneous nephrostomy drainage with malignant ureteric obstruction in prostate cancer, colorectal, and cervical cancers. The prostate cancer actually invades through the bladder neck muscle and reaches subepithelial connective tissue. The working hypothesis here is the prostate cancer ascends along the lamina propria to reach the trigone and uos within the loose subepithelial connective tissue before actually invading the more compact muscular propria and mucosa. And resecting these subepithelial tumor masses, we can achieve a longer obstruction-free time with androgen deprivation therapy and stenting. We present a case series of 6 patients who underwent palliative transurethral resection of the prostate and transurethral resection of the bladder tumor for malignant bladder outlet obstruction and malignant vesicoureteric junction obstruction. This is a subgroup analysis of broader prostate cancer cohort from the Department of Urology, Monaragala. It's a retrospective study of 6 patients, completed short-term outcome data operated from June 2022 to June 2023. The objective of the study was to assess the outcome of resectional exploration of intramural ureters and retrograde stenting in advanced prostate cancer patients with malignant vesicoureteric junction obstruction, followed by adjuvant androgen deprivation therapy as a palliative surgical option. And this, ladies and gentlemen, is how it would look. The angry-looking mucosa, contact bleeding, and this hematuria and ulcerated prostate cancer. And the ureteric orifice region, usually not very evident, infiltrated by tumors. And this is what we have done. We have resected the prostate, and we have resected the trigone, and in this case, the hydronephrosis was on the left side, and we have found the intramural ureter on the left side, and we have managed to put stents in retrograde fashion. So all had palpable bladders indicating significant bladder outlet obstruction, high serum creatinine, hydronephrosis, and hydroureter, and 50% of them had bilateral obstruction. And DRE showed fixed hard prostate, possibly invading the bladder base. 4 had palpably distended seminal vesicles, indicating obstruction of the seminal vesicles as well. All had palliative TURP to relieve the malignant blood outlet obstruction, and the TURP was essential part of this operation to reach the trigone and the ureteric orifice region for the resectional exploration. Mucosa overlying the trigone was near normal in all about 4 patients, with tumor bulge noted to surround UOs at least on one side. Ureteric region was obliterated with no identifiable ureter on both sides in 3 patients. And this is a summary of the results. 2 patients we failed to put stents, and those 2 patients we planned for bilateral PCN. The first patient had to have bilateral palliative PCN long term. All 6 patients had high-grade, high-volume mesenteric adenoprostate cancer with Gleason sum score above 8. 4 patients had successful resection, and 2 failed resectional stenting. And all of these ultimately had improved quality of life, improvement of obstructive uropathy by 3 months. These are the cases of the 2 failed patients. Patient A had anaplastic prostate cancer, Gleason score 5 + 5 = 10, aggressive cancer, and he needed a bilateral PCN initially to resolve anuria and high serum creatinine. The TURBT was unsuccessful finding out the ureters, but then he started draining urine. We did a cystogram, and this cystogram shows reflux into the left ureter. And the success lasted only shortly, and he needed long-term bilateral PCN. This patient number 2, he was oliguric on presentation. He had a successful palliative TURP. Again, we failed to find the intramural ureters on both sides. He was planned to have bilateral percutaneous nephrostomies. In fact, he went twice to the interventional radiology, and he refused. And then after the histology, he had bilateral occipectomy. He started draining urine little by little. After bilateral occipectomy, his obstruction got relieved, serum creatinine dropped, and he was not having any hydronephrosis ureter by 3 months. And in conclusion, ladies and gentlemen, palliative TURP and TURBT to resect and explore the intramural ureters for internal urinary diversion together with androgen deprivation therapy offers an excellent palliative option for advanced prostate cancer patients with malignant bladder outlet obstruction and malignant vesico-ureteric junction obstruction. This fulfills the essential requirement of palliative care, improving renal function, quality of life, hope, and chance for therapeutic options in advanced prostate cancer patients, at least in the short term. We are awaiting long-term outcome data at 6 months and 12 months. This also opens avenues for further research in this regard to produce robust evidence in multicentric studies in centers where radical resections are undertaken in palliative setting. I take this opportunity to give you a little idea about how palliative surgeries can sometimes enlighten our patients' lives. In the allopathic medicine, patients' treatment was pointed at relieving symptoms, caring, and if possible, curing the disease. But somewhere along the mid of the century, everything changed. We were focusing more on definitive diagnoses, definitive investigations, definitive treatment modalities, and the focus of attention was on the curative option therapy. But by doing that, I think we lost the humane touch of medicine and thinking about the palliative nature of care we can give. And I think as urologists, without exploring new ways to help these palliative patients in this regard, will help our palliative patients as well, rather than focusing solely on the curative intention therapy. With that, let me wind up with a quote from Mother Teresa. She said, best palliative medicine is tender loving care. With that, I thank you.
Very nice presentation. I particularly liked your reflections about palliative medicine at the end. That was very nice. I just wondered, the patient who had the orchidectomy actually responded very well without nephrostomies or stents. Had you considered that as an option, as a primary option for the other patients? Was there any reason why they didn't have androgen deprivation as an initial step? Could some of them have avoided stents and nephrostomies?
Yeah, so as I have mentioned, the gold standard of care is percutaneous nephrostomy. So we were actually pushing him to get the nephrostomies done because we did not believe that this will lead to resolution. It was also, we were actually amazed of how this happened. But what I feel is by resecting the tumor mass in the subepithelial connective tissue, even though we actually did not find or stent the physical ureters, the androgen deprivation therapy would probably reduce the swelling and shrink the surrounding tumors to maybe later open up the passage. Because this patient did not have anuria to begin with, he was only oliguric and moderate hydronephrosis hydroureter. And in fact, I personally spoke to this patient at least 3 times to try to convince him, and I even spoke to the interventional radiologist to arrange a theatre session to put the PCN under anesthesia, which was very difficult in our setting, but to all our bewilderment, he recovered. I think that relates to the tumor shrinkage of the related to the androgen deprivation therapy. Especially, the modality we are using is the bilateral orchidectomy due to lack of all these injectables. So maybe it achieves a...
Bilateral orchidectomy is a great androgen deprivation therapy. It's
It
probably
is.
underused.
It
but
is.
I think this patient made a good choice, personally.
Sorry, ma'am?
I think this patient made a very good choice. He lived without tubes for those 3 months. Thank you very much.
At the end, yes. Thank you.
My point is, technically, if you have blind resection searching for the ureter, what is the parameter or criteria or limitations that you are doing during resection?
Yeah. To give a little insight on this, even though I have presented and done this firsthand there in Monoragala, I've seen some of these being done by our mentors, especially the experience comes from the urothelial tumors in the bladder, where we resect and resect the tumor. And by doing so, we come across the intramural ureters at times. I understand the concern, sir. I think that is very true in terms of very advanced high-end malignancies. The tumor would definitely invade through the intramural part of the muscularis propria, and sometimes it will also ascend along the ureters, ureteric muscles. And sometimes obstruction is not limited to that. It is also included in the distal ureter where the lymph nodes are there. So in those settings, I don't think this is a very good option. The other thing is, I think with this limited experience, patients with anaplastic disease, like Gleason score 5+4, 5+5, maybe those are not the group of subset who should be offered this sort of care. Maybe we might fall into the trouble you are hinting at. We might resect and we might perforate the bladder. So maybe for the less invasive sort of disease, when they're initially presenting, we might still be able to help them out. So that's why I said maybe we need to do larger scale studies. This is a very minimum number patient study. And we probably need to collaborate and do multicentric sort of a study to really elaborate on how useful this technique is. In the longer term, I feel this is probably not enough to make any practice change, but this is always a possible thing when you're experienced enough to resect boldly in the region of the ureteric orifices, if you feel you are safe and if you are competent in doing that.
Hilary, can I just ask, all the patients presented in retention, they had a palpable mass. How long between when you put a catheter in, when did you decide that you needed to take it further, that it wasn't just bladder outlet obstruction that was their problem, because they all would have been hydronephrotic in retention?
Yeah.
So was there a gap, or was there a group of patients who just had a catheter that you recovered and then just did a TUR?
Yeah. So I think the question here is whether this is high pressure chronic retention due to malignant obstruction, which can be relieved by catheterization and relieving the bladder. So the principle we adhere is like if the serum creatinine level is more than 2, we put the catheter and observe for post-obstructive diuresis, electrolytes, and optimize them before we actually discharge home. And these patients, they initially present, except one patient who came 9 years after orchidectomy. All the other patients were first presentations. So they had the biopsy, and once it was confirmed, they had the operation. So most of them, I think the duration they had the catheters in, I do not have data to elaborate on. Most of them, I think I probably don't have enough data to answer that question exactly. But the side question to that is probably whether this was high pressure chronic retention related to malignant bladder obstruction. I think this was well beyond that. Even though I do not have photographic evidence of all these patients, this was the only patient I had evidence. All of them had physical invasion of the trigone and the ureteric orifice regions.
Sorry, one more question, probably the last one from this table. Is another option, surgical castration is definitely one of the easiest thing to do. However, if it is not possible, use of the AR agent, the new generation hormone therapy, abiraterone, and I understand that cost may be prohibitive at certain locations in this part of the world. Ketoconazole is an option that I have used for many years prior to the easy availability of abiraterone. So these are the two drugs that you can use for certain emergencies like neurological as well as obstructive uropathy. Thank you.
Yeah, thank you very much, sir. We can use that for spinal emergencies as well, if I may add another point. Right, palliative ureteric reimplantation. Yes, right. That has not been tried. What I have seen in one of these patients who failed, he had the prostatic tumor invading more than half of the bladder. So the prostate cancer actually ascends up in the bladder. I think potentially speaking, if the patients are fit enough, even a ileal conduit is a better option, I think, rather than, because it's probably going to get obstructed as well. I have not personally tried that. It can also be given a try. But say if you do it laparoscopically, I think then the incisions are very minimal. And then it could be a potential surgery as well in the palliative setting, especially if the minimally invasive techniques are used, then there is no major cut on the patient. So the very next day, patient is mobile. So if we can incorporate that, I think probably it will be a better option as well. So when you reimplant, you implant to the fundus or anterior aspect of the bladder, then it takes longer time for the prostate cancer to invade to that point. That's right. I think that's also a good suggestion. But I think it has not been tried anywhere though.
If the patients are fit enough, then we can try in those cases.
Yeah, exactly.
Thank you.
Hilary, I have a question for you.
Yeah.
Is there any experience in your practice that you did the same thing for the carcinoma cervix bilateral malignant ureteric obstruction?
So I think in that instance, the carcinoma of the cervix invades outside in, and it actually distorts, destroys, and invades the ureter. And often we fail to find and retrogradely stent. And the other thing is stent drainage-wise, its majority is around the stent rather than through the stent. So in serous tumors, when the tumors are constricting from all around, the chances are the stent might get obstructed, especially this normal polyurethane stents we use, not the Rouge stents or the tumor stents I'm talking about. Even Rouge stents get obstructed maybe about 3-4 months' time in tumors and radiotherapy-induced strictures. So I think in cervical tumors and in tumors in colorectal tumors, I think the best possible option is percutaneous nephrostomy still. And also in advanced prostate cancer where the distal ureter and the distal due to lymph node masses and all, then again, I think still the PCN is the option.
Thank you. I think, Dr. Fernando, sorry, we've had a wonderful discussion. I think in the interests of fairness, we probably ought to say 2 minutes of questions for each paper, but thank you very much. And I'll hand over to the professional, Master of Ceremonies, Ma'am.
Thank you, sir.
Thank you.
Following him, we will have Dr. M. N. Herath delving into a Sri Lankan experience of a novel approach to synchronous bilateral percutaneous nephrolithotomy, a 7-year journey. The stage is yours.
Good morning, ladies and gentlemen. I'm Dr. Herath, Relief House Officer in GU Surgery at TH Kalutara, and I'm going to present a summary of our research, which is a Sri Lankan experience of a novel approach to synchronous bilateral PCNL, a 7-year journey. There's an increasing incidence of renal stones worldwide, and it poses a significant healthcare burden. Bilateral renal calculi have been traditionally treated with staged procedures as this was deemed better. However, recently, bilateral synchronous PCNL has become a renowned technique. Our objective was to evaluate the clinical efficacy and the perioperative morbidity of a novel surgical approach in a series of patients who underwent bilateral synchronous PCNL and to determine the composition of the renal stones. So our study design was a descriptive case series, and we obtained data of 51 patients from 4 tertiary care hospitals in Sri Lanka. We included all patients who underwent bilateral PCNL over a span of 7 years. The stone parameters, such as the size, density, and the location, were assessed using NCCT. The clinical efficacy was determined by the stone-free rates, the surgical time, and the requirement for ancillary procedures. The stone-free rate was taken as the complete absence of residual stones on follow-up imaging at 4 weeks post-op. The surgical time was measured from the time when the patient was placed in prone position until the dressings were placed on the tracts. The requirement of ancillary interventions was the need for either medical or surgical interventions. The perioperative morbidity was assessed by the length of hospital stay and the postoperative complications, which were assessed using the Clavian-Dindo classification. So our surgical technique actually differed from present literature such that both sides were cleaned and draped simultaneously, and punctures to both sides were made at inception. Also, the less complex side was dealt with first, and neither the operating table nor the image intensifier were moved from their original positions. The above measures actually helped to reduce the operating time significantly. Now, when looking at the results, we can see that most patients were male, and the mean age was 47.3 years. I would also like to emphasize that we had 3 patients with horseshoe kidneys, 5 staghorn calculi, and 9 partial staghorn calculi. The stone diameter ranged from 1 to 5.3 centimeters. The median stone density was 1,200 Hounsfield units, and the mean Guy's stone score was 1.7. The median operating time was 80 minutes, with 180 minutes being the longest. When assessing the tube status, 48% were totally tubeless, 50% were tubeless, and 1.96% required a nephrostomy tube. When analyzing the stone clearance, 94.1% had complete clearance, and 5.9% had residual calculi. 3 patients required ureteroscopy and laser lithotripsy as ancillary procedures. When talking about the post-op complications, 1 patient developed clot colic and 6 developed post-op fever, but they were all managed conservatively. The average length of hospital stay was 2.1 days. As you can see, 110 renal tracts were made in 102 renal units. Majority were lower calyceal punctures. 94% had only a single puncture per renal unit. Majority of the access sheets were less than or equal to 16.5 French. When analyzing the stones of 29 patients, 96.5% were calcium oxalate and 3.4% were uric acid. When comparing our study with several comparable studies, we can see that our mean surgical time was comparatively less, and the need for ancillary procedures was also less. So in conclusion, this study has demonstrated that SBPCNL using the novel technique is safe and high in efficacy. Also, I would like to elaborate that this technique has helped to reduce the total anesthesia time significantly, further establishing its efficiency. Thank you.
Congratulations. That is a very good presentation.
Sir.
And I have a few questions. You said staghorn calculus. Now, staghorn calculus, did you clear it in one puncture or require more than one puncture?
It usually requires more than one puncture, sir.
Yeah.
Yes.
Because we are doing it. Maheshwari has also presented a paper, bilateral PCNL together. But our thing is stone size, a single stone in pelvis, maybe 2 centimeter, 3 centimeter bilaterally, and we use the mini perk. But you are doing the tubeless procedure, that is very nice. And only thing we put bilateral DJ. One thing I would like to say, how do you evaluate the residual stone? Do you do CT scan?
We usually evaluate it using X-rays or ultrasound scans, sir, because NCCTs are not widely available, and if a patient has to get it done in the private sector, it's also expensive. So because of that limitation, we didn't use NCCTs to evaluate the residual stone volume.
Initially, that was our problem also, but then we realized that very often we miss the stone, and they are bilateral stone. So they have a tendency, a metabolic tendency to form a stone again. So total stone clearance is very, very important. So now we do a CT scan, and in a kidney area, we do the puncture, which is a 5 millimeter cut. So even a small stone would be seen, because stone free is very, very important. But still, this is a good method where you clear, you've done a stone analysis. we do the metabolic study, and then we try to do, if there is any family history, then like to look the genetic thing. Vaishwari?
Excuse me, two comments regarding to non-moving the C-arm for bilateral puncture. How you manage that in the operating theater? This is one. The second, in this study, you didn't evaluate the hemoglobin or the need of blood transfusion, especially in bilateral in comparison to staged for each side.
When we initially clean and drape the patient, we keep the C-arm in a position where both sides can be assessed. So because of that, we didn't need to move the C-arm. And regarding blood loss, in our study, patients did not have a significant blood loss, and none of the patients required transfusions post-operatively.
That's a very nice study. I have got two small questions. One is, why do you want to puncture both sides simultaneously? Why not complete one side and then go to other side? If you do both sides simultaneously, and if you have a problem on either or both sides, then there is no way of coming out. And second is, when you are doing bilateral, do you have two teams operating, or it is the same surgeon who shifts from one side to other?
The same surgeon is doing both sides, sir. The operating surgeon is actually in the audience.
I know that.
Yeah.
Two surgeons are working together.
Yes.
At our place, two surgeons are working simultaneously. So time taken is much less. But then we do ultrasound guided puncture, because the fluoroscopy time is very, very important, because they have too much exposure to the lots of team. So we do ultrasound guided puncture, and once we have a clip, small fluoroscopy. So that is it.
So could you, it's a very nice presentation. So
Thank you, sir.
did you finish in all the cases, or you have to, sometimes you finish one side, there's some problem and could not complete the bilateral?
Well, we have actually completed both sides, sir.
Yeah, because I've also published a bilateral simultaneous PCNL. Out of 65 cases, we had to, a pre-planned case, we had to actually stop on one side and then decided to do it later, you know. So.
Thank you.
For the sake of the time, we should move to the next, please.
Thank you, Dr. Hera.
Thank you.
Next, Dr. Coelho Victor will provide a comprehensive analysis in his study on the sensitive and specificity of multiparametric MRI, PSMA PET, with final histopathology as a gold standard. Over to you.
Good morning, respected chairpersons and faculty here. I am Victor, a resident from the Muljibai Patel Urology Hospital, Nadiad, and we will be presenting our work entitled A Diagnostic, Descriptive, Analytical Study Correlating the MPMRI and PSMA PET findings with the final histopathology findings in patients who have undergone a robotic-assisted radical prostatectomy. At the beginning of the presentation, I will be giving an introduction why we went about this work, the background regarding the presentation, my aims, methods and materials, results, and finally the conclusions. To begin with prostate cancer, when PSA was used as a screening tool to detect prostate cancer, this is a randomized study that was published in the NEJM. And when they kept PSA as a cutoff of 3, what they concluded was nearly 1,060 men had to be screened, 48 men had to have a curative treatment in order to save one man's life. The problem with PSA comes in the gray zone when it is between 4 and 10. The sensitivity and specificity can be as low as nearly 21%. In order to counteract the drawbacks of the PSA and to understand the anatomical and functional prospect of the prostate cancer, came the MPMRI staging and the PIRAT staging, which looked at T2-weighted imaging, diffusion-weighted imaging, and dynamic contrast enhanced MRI. However, even the MPMRI had its own drawbacks, which showed that the specificity was only 36 to nearly 58%, and with two components, the seminal vesicle involvement and lymph node involvement, the sensitivity can be as low as 30 and 33% respectively. In order to counterattack the MPMRI, came the PSMA PET, which gave us a local understanding of the disease as well as metastatic understanding of the disease. And in a publication, what they concluded was that the intraprostatic localization using the PSMA PET was 95% specific, and 80% of the lesions were actually picked up on the PSMA PET. However, PSMA PET also had similar drawbacks, with the cancer detection rate being as low as 33%, in some cases as high as 99%. So this was a meta-analysis that was published in the Journal of Oncology, which actually compared the MP-MRI findings, the PSMA PET findings. And what they concluded was that both the imaging modalities have to be used in conjunction with each other. With this background, the aim of our study was to understand the performance of the gallium PET and the MP-MRI in the detection of prostate cancer in patients a PSA ranging from 2 to 78, and to compare the similar findings on these imaging modalities with the final histopathology report in patients who have undergone a radical prostatectomy. This is the diagrammatic representation, what I tried to compare, the MP-MRI, the PSMA PET, and the final histopathology report. The primary objective was to correlate all the findings with the imaging findings and the final histopath report. The secondary objectives was to calculate the secondary detection rate of MP-MRI and PSMA PET, and to correlate the SUV value max of the PSMA PET with the final histopathology report. It was a retrospective study carried over a period of 8 months after IRB approval was obtained. The age group of our patients ranged from 40 to 85. All the patients had a suspicious DRE finding, and all of them had undergone a transrectal biopsy, had an MP-MRI PET and a gallium PET done. The statistical analysis were calculated using mean, and for the SUV max value and the association between SUV max and the PSA, we used the ANOVA testing. Coming to my results, the sample size was 60, the mean age was 67 years, and the mean PSA at index presentation was 20.17. The histopathological reports, the TRUST biopsy, majority of the cases had nearly 47% of the cases were grouped as 4+3. And on the final histopathology report, after the prostatectomy, most of the lesions were 40% of which were staged as T3B. Now, what is the actual detection rate that we found out in our series? The MP-MRI actually detected cancer in 58 out of the 60 cases, giving a detection rate of 98%. The PSMA was able to detect cancer in 57 out of the 60 cases, giving a detection rate of 95%. Coming to localization. Localization we defined based on sectoral maps that we drew on the MP-MRI as well as on the histopathology report. And what we found as when these two correlated, we said that it is actually well localized. So MP-MRI had a higher localization, had a localization rate of 86%. The PSMA PET had a localization rate of only 68%. This is the diagrammatic representation of the MP-MRI, the sectoral diagram representation where the lesion is in red on the MP-MRI, and the final histopath whole mount specimen, which is correlating here. The secondary detection rate was found to be much higher with sensitivity in the MP-MRI group as compared to the gallium PET, which was 38% sensitive. This is to summarize our results. The detection rates were higher in the MP-MRI group. The localization rates were also higher in the MP-MRI group. Seminal vesicle involvement was nearly the same, and secondary detection rate was much higher in the MP-MRI group as compared to the gallium PET group. We now wanted to understand the relation, is there any relation between the SUV max value and the Gleason grade group? And what we saw is, as the grade group increased from 1 to 5, we see that the SUV max value also increased, and that was found to be statistically significant at a p-value of 0.04. We then actually tried to understand, is there any relationship between the tumor quantification, the volume of the cancer, and the SUV max value? For that, we actually grouped the SUV max value into 3 groups, less than 2.5, 2.5 to 10, and more than 10. However, that did not give us any statistical significance. It did not correlate with statistical significance, the volume of the disease and the SUV max value. To conclude, the detection rate of the MP-MRI and PSMA PET in detecting the primary prostatic lesion was 98 and 95%. For exact localization, MP-MRI outscored the PSMA PET. Lesions, the index lesions, the SUV values ranged from 4 to 29, and what we saw is, as the SUV max value increased, the grade group of the ISUP grade increased. However, that did not correlate with the volume of the disease. So there could be a possible role for fusion MP-MRI and PSMA PET in the future. Thank you for your patience.
May I ask you questions?
Yes, sir.
You mentioned the sensitivity of lymph node detection, but
Yes, sir.
If you mentioned, I'm not sure if you told us what you did, if any of the scans showed positive lymph nodes, did you continue with the prostatectomy, or were these lymph nodes removed?
Yes, sir. I did not look at that data, sir, whether the post histopathology report of the nodes were positive or not in this case. I only looked at the imaging findings, sir. That is a drawback.
But if the lymph nodes were positive on imaging, did you proceed with the surgery?
Yes, sir. All of these, this is a retrospective study. So all of these patients had already undergone the robotic assisted radical prostatectomy.
Thank you. Very nice presentation. Can I ask, how do you think the PSMA PET changed the management or would change the management of these patients? I was finding it difficult to know how that in the tumour board, how it would in reality change management.
Ma'am, the background actually for this study was we have our tumor oncology board, we have uropathology meetings, and what we see in those meetings is the imaging findings sometimes could say it is a localized disease, it's a T2 disease. But when we get the final histopathology report, sometimes it is advanced, or even contrary, 30 to 40% of the cases don't correlate with imaging findings. There are certain cases where the malignancy may not even be picked up. So to understand that correlation, the MPMRI, the exact findings of the MPMRI, the PSMA PET, and keeping the histopathology report as the gold standard. That is why we wanted to actually analyze these three imaging modalities prior to that. No, it did not change any management option.
In my thinking, if you don't mind, the role of the PSMA PET is detecting distant disease, isn't it? Yeah.
Very nice presentation.
Thank you.
See, there are two parts to my question. One is that literature says that for as far as lymph node metastasis is concerned, PSMA PET is much superior to MPMRI.
Right, sir.
Your study was a bit reverse to that. And if suppose there were lesions on MRI, did you do a systematic biopsy or a targeted biopsy? What was
No, sir. We actually conducted systematic biopsy only. And maybe in a few cases we have conducted targeted biopsy also, but not routinely all of the cases.
Actually, routinely we do systemic biopsy. But since we are doing the study with MRI and comparing with that, so whenever there's MRI source, we do targeted biopsy first and then systemic biopsy. Because very often we find that in a final histopathology, you have a tumor as seen in MRI, but there are still more tumor. And then you would like to see it. And secondly, regarding the PSMA scan, very often we had a radical prostatectomy and then we did an MRI. And afterward, the PSA started rising. And then we did a PSMA scan and we found a lymph node. Now, if the PSA is high and the biopsy before doing a biopsy, we tried to do the PSMA and then he did a correlation, sensitivity and specificity of that. So ultimately, our aim is to detect earlier we do the diagnosis, first staging of the tumor before we do that.